Croeso i'r digwyddiad gyntaf i'r raglen gwasanaethau a mysodiadau Rywol Cymru. Welcome to the third in the series of the first set of Welsh Sexual Assault Services programme events. Today, our series is going to be looking at Black and ethnic minority, LGBTQ+, and older people. First off, I'd like to go through some housekeeping rules. I'm Jo Williams, by the way. I'm the Director of the Welsh Sexual Assault Services programme. Just to let everybody know that the session today is going to be recorded, so if everybody could please turn off their cameras and microphones. The chat box is going to be open for any questions and comments which can be asked to the speakers at the end of their session. They can either be responded to as part of the question and answer session in the chat or followed up after the event. So today we've got another jam-packed agenda. Opening the event, we have the National WSAS Advisor for Wales, Yasmin Khan. We've got presentations from East, Bowser, a consultant and facilitator for LGBTQ+. The Deputy Commissioner for Older People, and Dewis Choice. We have got a hashtag for the event, so if anybody's tweeting, if you wouldn't mind, please using our hashtag, which will be put into the chat bar as well. So it's WSAS Learning or Dysgu Gyrc. Just to say about the event today, some of the content is quite emotive and can affect anybody. If you are affected by any of the content, please feel free to leave the session, and we have the Live Fear Free helpline that you can contact as well at any time. And the number is 0808 8010 800. That'll be posted in the sidebar as well if anybody needs to use it. So welcome again to our event, and I'd like to introduce Yasmin Khan, who's the National Advisor for Violence Against Women, other forms of gender-based violence, domestic abuse and sexual violence to open our event today. Thank you, Yasmin.
And thank you, everybody. I'm delighted to be here today. I hope everyone can hear me okay.
Yes, we can, thanks.
Brilliant. Okay, so yeah, I'm absolutely delighted to be here today and to be speaking at this very, very important couple of days, which have really kind of shone the light on so many issues around WSAS, and I'm really pleased that we are putting some focus onto issues and the complexities around BME abuse within Wales, because it's something that we really need to focus on and make sure that we are responding in the way that we need to. So I'm really pleased that the Collaborative and the Welsh Sexual Assault Service have combined their efforts into this this particular spotlight. And it's really important because we've got to have a better understanding of the multiple risks that affect Black minoritized communities. And before I start, really, it's really important to understand that terminology is a very interesting thing. And as far as I've been working in this field, the political climate and the landscape has changed somewhat. So before it was okay to use Black, Asian, minority ethnic. Now we tend to use the Black minoritized ethnic communities. And I think for me, it's really important to ensure that we look at abuse through an intersectional lens to ensure that our responses and the protection that needs to be afforded can be done so according to a victim's needs. And I think really that's the backdrop of the kind of issues that I'd like to raise. So why do we need to specifically focus on the particular issues that families experience from the Black and minority communities around WSAS? Now, it's really important to have the understanding of what those risks are and the particular barriers and the challenges communities face. And we've really got to have remove the monolithic approach we have to violence against women and girls, because I'm really pleased in Wales that we have that approach, and honour-based abuse, forced marriage and FGM, which is what we really define the specific abuse in Black and minority ethnic communities, although it's not exclusive, is really where we kind of frame the discussions around that. And we also need to identify that, you know, gender-based violence primarily affects women. And for the purposes of the figures, 74%, over 70% of victims are female, although we are seeing an increase of victims who are men, and that's reflected in national data too. So honour-based abuse, forced marriage, FGM, it's really important to understand the multiple complexities and barriers victims experience. And Safe Lives produced a spotlight report on these particular issues, and it's evidence within that report and research that's been done in this area that victims who experience honour-based violence and abuse almost have an additional 2 years of abuse in comparison to those not experiencing honour-based abuse. So if we look at the trauma and the impact of that abuse, the prolonged time that victims experience that abuse, it's really important to understand what support needs to be provided through health, and the impact, as we see now, of the pandemic, where it's reported over 80% increase in comparison to the same period of time in previous years. If we look at the impact for victims, it's profound. So not only have they been experienced abuse for a longer period of time, often in those confined spaces where restrictions have been very, very strict, they've had many more incidents themselves. And whether you have online, offline, in the home, this can have a huge impact on mental health. So we'll talk about that a bit later on. But in terms of accessing support, it's more difficult for victims. And if you look at that from a basic point of view, the language it can sometimes be a barrier. But the shame and the dishonour that they experience from the abuse is another reason why it's very difficult to access help at an earlier stage. And that's why prevention is very, very key. In Wales, we have an indication of what those figures are. We have many measures in place. We have a specialist provider who delivers the national contract. And it's really important that we have that cross-agency, cross-policy approach in Wales to ensure wherever victims present the abuse, that we have a multi-agency respond to that abuse, because it's often issues around housing. It's often issues that need to be around MARIC cases, multi-agency risk assessments, and child protection conferences. So we need to understand the severity of the abuse. It's estimated that 68% of the victims who experience honour-based abuse are at serious risk of harm, even honour killings. And so that's why when we are looking at the risk journey for victims, we need to identify the severity of risk can change. I've been working with my colleagues from Met Police in the work that I do in England. And over 4 years ago, there was a tragic honour killing, and the officer in charge spoke to me and said, at the point of disclosure, from the point of disclosure to her actual murder was 48 hours. So at the point of disclosure, when she presented herself to the police, she said she was in immediate risk, but within 48 hours, that risk had escalated to the highest level. So that just gives you an indication of how serious we need to take the reports, and also how quickly risks can change. So the risk journey for a victim within the BME community can be much more severe. And it's really important as safeguarding organisations with responsibilities that we work in partnership to understand what those risks are. You only have to watch Benaz Mahmood's documentary, where she presents the risks to the police officers and in hospitals, and she tells staff about who may present those risks and what action was taken. And there was an awful lot that was learned with the Banaz Mahmood case, procedures in place. But in terms of all that time that has lapsed, what we still don't understand is where those risks are presented. We have an understanding of the figures and the data, but the prevalence is something that we still need to understand much better in Wales and of course in England. So it's really important to recognise that this is something that we really must be working on cross government issue, which we are through the HBA leadership group, but through regional boards, through safeguarding partnerships, it's really important to have that better understanding. Because if we look at the element around prevention, we've got to identify who those are who are at risk. So whether they come through education or they're coming through health services, it's really important to understand, what those risks are and how those risks may change. And in Wales, we've done an awful lot of work around the public health approach to try to understand the root cause. In this area, in this space, where victims within the BME community, it's really, really important to engage the communities, working with the men within the community, working with families wherever they presented, so that we can actually start to identify who those communities are at risk, and they are changing, and what support they need, and how can we prevent that through education. Education is absolutely key. So it's really important to ensure that that response is engaging with communities. And I'll put the link of the Banaz Mahmood documentary by Dia Khan in the chat box after I've spoken. So it's really important, and working with BALSA over the couple of years and grassroots organisations. I was at an event where there was a male worker who was speaking to the wider community around FGM, and I thought that was a brilliant area of work to get involved in, because men are absolutely essential in changing that dialogue, protecting women and preventing the abuse in the first place. So those kind of initiatives need to continue, and there needs to be a long-term approach of working with communities and ensuring important to work with the BME organisation in Wales. It's also important to understand the multiple barriers victims within the BME community experience. So not only do they, because if you look at it from an intersectional perspective, understanding, navigating their way through services. I've made the disclosure, who do I contact for housing? What measures are going to be provided to me? Who do I need to contact? I speak to victims in Wales, and what they say to me is that they now have to speak to 3 or 4 professionals before they get the help that they need. So it's really important to understand that that one chance rule applies. So how can we as professionals ensure that we are sharing that information? We are instigating that joint action plan, and we are taking responsibility for the situation that the victim is in, and ensuring that that victim doesn't have to explain her situation, which is traumatic, to 4 different agencies. I spoke to somebody just before November last year, and they said to me they'd spoken to 5 different agencies before they got the help and support that they needed. And I know by listening to the trauma that they experience, even professionals listen to vicarious trauma, and I understand you're going to be talking about that, or you already have through the 3-day program. But that's so important. And by victims explaining their situation to 3-4 agencies, the risks could have escalated 3-fold, and the impact on that individual's health is profound. So that's what we've got to make sure, that we understand what those barriers are, and we can support where possible by working together and having a joint support plan. It has to be mentioned around migrant women, although there is some brilliant work going on in Wales through the Uncharted Territory report that Joe Hopkins is leading on, which is really a call for action for services of victims who have no recourse to public funding. It was really placed on the Domestic Abuse Act, a huge expectation that women with no recourse to public funding would be included in that. Sadly, that didn't happen. But in Wales, what we're doing is we have a group of stakeholders who are looking at the additional responses required for victims who have no recourse to public funding. Although local authorities have a discretionary fund, there is consistency across Wales, and it's how we can have a more cohesive approach. So there is work that is currently being done. I sit on the Domestic Abuse Commissioner's Office, support for migrant women who experience abuse. And one of the pieces of work that's going down, which Wales should be included in, is a piece of research which is going to be building on the pilot that BALSA are delivering across Wales, research into what more needs to be done, what funding needs to be applied, so that women who have no recourse to public fund can be supported. So it's really important that we are part of that dialogue. And I'm don't worry, I'm on the meetings, making sure that the Welsh landscape is really important and featured in that England and Wales approach. But we need to see, it seems to me, we are constantly making sure that Wales is being heard in many of those English and Wales programs and projects around the domestic abuse and the implementation around that. We have the WSAS Act 2015, and 7 years on, there is a considerable amount of work that has gone on in the area, not more so with the national strategy, which is being reviewed and is due to be published. It's been out for consultation, but I'm really pleased to say we have had specific campaigns so that we can increase public awareness around honour-based abuse, forced marriage and FGM. We have a survivors engagement network, and it's really important that all voices are heard. And although we have had engagement from Black and minoritized groups, we need to continue the journey of understanding the issues that are facing them and making sure that provision is supported. And through sustainable funding, making sure that commissioners jointly can work to commission services specifically for victims within the BME community is an area of work that I'm leading on in Wales. And although the Domestic Abuse Act didn't specifically refer to honour-based abuse, although it is included, the WSAS Act did. And I think the ministers and many of the key stakeholders are really committed to the issue to make sure that all victims are protected. So it's really important as part of the network, the safeguarding network, that we continue raising the awareness of public campaigns. We need to ensure that we also have very strong procedures, specific procedures around safeguarding and protecting victims from the BME community experience honour-based abuse and forced marriage and FGM, and breast ironing, cultural harms that are happening in Wales. And it's really important because I've just been involved in a serious case review in England, and you don't need to guess what the key learning themes are, and they are always around information sharing. They are always around training and making sure there's a specific reference to honour-based abuse, forced marriage and FGM. And I must say this because in some of that learning, there has been a lack of professional curiosity. So what I mean by that is by having a lead professional who has specific experience of working with victims within the BME community or has additional training, they then become one of those areas of expertise within the organisation or within a partnership. That was lacking in the serious case review. There needs to be professional curiosity, and to do that, when you are supporting families from diverse groups, in the serious case review that I was involved in is the cultural competencies, the frameworks around that need to be implemented. And coming on to some of the wider learning issues, there were specific recommendations for policing. So specifically around the events that you're having, one of the things that you may want to be aware of is I was involved in a police super complaint. So there's been a request from the Inspector of Policing, the Home Office, the IOPC, the Independent Office for Police Complaints, for charities and NGOs to come forward and investigate an area of policing, but not be restrictive to one police force. So we had to do academic research, we had to look at organisations in England and Wales, we had to look at failings around the reports of sexual abuse within Black and minoritized communities. And we were one of 17 super complaints, one of only 2 BME organisations. I'm talking about the Halo project that I found and I'm a director of in England. And there were 9 failings around investigations. And again, I think that's really important to look at, and it's been upheld. That complaint has actually been upheld. And I'm working with the HMIC FRS to look at what further evidence can be provided. And of course, one of the outcomes of that report may well be that police forces in England and Wales will have to do a thematic review, or that their training may need to include some of the recommendations that we've highlighted. So in terms of the groups that are already working on issues and improvements for victims of honour-based abuse, there is a leadership group, and a couple of weeks ago, the HBA leadership group across Wales almost did an assessment of what more needs to be done. And one of the areas that we're looking at is how are regional boards, safeguarding boards, engaged in having that understanding, better understanding of protecting victims of within the BME communities. And there's a range of recommendations within that. So if there are professionals on the call today, it's really important that you attend those meetings or have sight of some of the outcomes of that meetings, because we've really repositioned where the interventions need to lie and what policy needs to be developed. So I would really ask you to work with BALSA and the Welsh officials who are facilitating that group, because there is a kind of shift in emphasis of where those priorities need to be. Another area I just want to pick up on the series case review that we've been involved in is the issue around professionals having that confidence. So if we look at the learning from the Rochdale, Rotherham, Oldham and other areas, I've mentioned this in the super complaint, we look at the areas around safeguarding protection versus culture and race. And what I mean by that is when we're supporting victims within the BME community, we must always prioritise safeguarding and protecting. But what we must consider thereafter is race and culture, but not the other way around. And if you look at some of the learning in the case review that I've been involved in and the learning from the Oldham and the grooming gangs, it's really important to have that as a key focus. So if we focus on protecting and safeguarding, we're almost there. We can focus on the race and the culture thereafter in terms of, how do we engage with those communities? We always need to make sure that we look at that through a victim lens and not a perpetrator lens, in terms of some of the findings have been around the community impact assessments that were done, or making sure that, we don't upset some of that apple cart, the race equality apple cart. But we're focusing on safeguarding protection, we will never upset the apple cart. We will look at the particular issues we need to consider when we're carrying out that investigation. If you're policing or if you're doing safeguarding, it's how do we protect the victim first? Because when they make the disclosure, that's when that risk escalates, and that coercion, that kind of, if you tell if you tell the authorities, then you're going to bring shame on the family, not the issue themselves, not the issue itself that has affected and instigated that disclosure, but the emphasis that the victim really needs support around is, once they've made disclosure, what can you do for them? So we need to understand the long-term support that victims need, and we need to also frame that within the profound impact the abuse may have caused to the individual, and the impact on their mental health, specifically for these events and the agencies on here. So therapeutic services, psychotherapy services, counselling services must consider the impact of shame and dishonour and how that impacts on the victim and the impact of the support that's then required. I've worked with many victims who've experienced FGM, female genital mutilation, and the impact of post-traumatic stress disorder on them because of the abuse is unbelievable, and it affects their life. It affects how they interact with their children, you know, what they go through on a daily basis. And although there is help available, we really need to make sure that that therapeutic service, the counselling, the post-traumatic stress disorders provision includes FGM, the impact of FGM on an individual, you know, the impact of threats to life on victims of honour-based abuse, the fact that victims of honour-based abuse can also be victims of forced marriage and can also be victims of FGM. So we really have got to, that classification we record as agencies needs to look at the multiple vulnerabilities victims experience, and then looking at what services they need, housing, social care, help with benefits. They need so many services, and yet they're expected to let us know what they need. We should have a all-rounded support plan and working with organisations like BALSA. I spoke to a victim who said to me, you know, abuse is like a bereavement. When it happens immediately, everybody's around me, but it's thereafter when all those services are gone, that's when I need the support. If you're pleased to know, I'm almost finished. So what can we do in Wales? Sadly, I don't have the video, and I've tried to upload it onto this call. I will send it to colleagues on the call today so they can disseminate it. We need to make sure we embed that culture of safeguarding and protection before race and culture. We need to start recording those multiple risks and vulnerabilities victims face within the BME community. We need to understand the complexities of the referring agency and our shared responsibilities around safeguarding, cross-area support. So if a victim is in North Wales and they're going to be transferred to South Wales, we need to make sure the support plan in South Wales accommodates some of that learning in North Wales. We need to make And just very briefly, the one chance rule, that was what the DVD was focused around. Victims come to us with their situations. They have their one opportunity to tell us. Once they tell us, it becomes our responsibility. I'll send the links in the chat group. I'll also send the video and links to the super complaint as well as to the Bernard's Memo directory. I think we do some great work in Wales. We've just got to carry on the momentum. Thank you.
Thank you, Yasmin. That was really, really insightful, and I think I got a lot of information from you today. And we can share all the links and everything both in the chat bar, and we'll make sure that they're on our website as well, so that everybody can access them after the event. So thank you for opening the event today and speaking to us. So moving on to our next presenter. So Fatiha Ahmed, sorry if I pronounced that wrong, Fatiha, is the BME Children and Young People Project Lead and East Training Associate, and her presentation today is going to be working with BAME children, young people and families. Thank you, Fatiha.
Thank you, Joanne. Morning, everyone. My name is Fatiha, and I'm currently leading the BME CYP project at East Cross Wales, as Joanna said, supporting children and young people aged 0 to 25 with multiple needs. I'm going to talk about some of the challenge and barriers children and young people face in relation to child sexual abuse. Next slide, please. Before I begin, I just wanted to talk about a little bit of EAST, what we do, and our vision. East Wales is a unique award-winning organization set up in 2005. Since then, it has expanded its remit to support BME young people, to support the BME families, individual across all ages of individuals and across Wales. And the 5 areas we support is BME young people, BME families, refugees and asylum seekers, supporting the BME community groups, and challenging racism in the wider community. Our vision is a Wales where BME young people can contribute, participate, and feel they are a valid member of society. And our mission is to provide quality service which empowers BME young people, families, individuals to work effectively with mainstream partners, to influence policies and practice, to promote diversity and improve public attitude towards ethnic diversity in Wales. Next slide, please. So as you know, we support and look after children and young people at EAST, and one of the recent project we work with is where Welsh Government commissioned us to do, and we are very pleased to do that. And by doing that, we have actually supported many families who actually come to us and disclose, and through Stop It Wales Now, we provided that support. So some of the things I'm going to discuss today, what we have been doing in partnership. So EAST have been commissioned by Welsh Government to work in partnership with Stop It Now Wales project to on the prevention of child sexual abuse and how to engage with BAME communities. This is the first thing we were approached with. It's like, how do we engage? We said, it's okay, we support you with this. So we have been asked to give recommendation ways forward for the current toolkit they had, and also both for a BAME organization and communities, which will be easier to use. So what we have been doing, we have done like 2 BAME parents focus group, and which we had over 30 parents attended from very diverse background, and some of them had language barriers, but we supported those women to overcome the language barrier, and we got feedback from them. We also conducted a survey, asked BAME communities for engagement and ideas to receive what would you like to see in the future booklet. So we had over 30 responded on this. As part of this work, we delivered a focus group with professionals where we invited practitioners who work with the BAME children and families to share their experience and suggest some of the ideas. And also we wanted to know what was their barriers when it comes to engaging with the BME children and young people. Next slide, please. From this partnership work and our existing experience, we have identified some key barriers in the BAME communities in relation to children and young people, child sexual abuse, which I will outline now. Stigma. One of the biggest one I come across often when family comes to me and when they are talking about this topic. Stigma is always at us thinking of how can I disclose? Often, seen as negative, and think they will bring shame to the community. Amongst many community, reputation is often a big factor when it comes to child sexual abuse disclosure. That's really sad. And second thing is language. Language. Parents usually don't speak to children about sex anyway. So imagine talking about sexual abuse is far more painful. So often they find it difficult to find the right terminology to talk about this topic. Communication, barriers between children and parents. Children do not speak fluently in their own language, and they are far more comfortable only speaking in English. So on the other hand, many parents may not speak English, And so the children find it very difficult to express any inappropriate behavior happen to them. So as Yasmin mentioned, terminology is so important, but children don't have those terminology in their own language to express those feelings. Cultural issue we have, which prevents people from speaking out about this taboo subject. If parents are separated from female, child would not share anything to her dad, or male child will not share anything to his mom. And there's a lot of cultural norms actually prevents children from disclosing or coming forward. Or even parents, they say, what if the community found out? It's always about the shame and name. Fear of losing child or child going into care if they disclose. Even recently, when we were delivering the launch event, and towards the end, one person disclosed, and the highest fear they had, there was 4 siblings in the house. 2 older girls got abused by their dad, but the younger 2 children, they're thinking if they disclose and dad still living in the same household, what if those younger 2 children are taken into care? That was their fear. And also girls getting married into a respectable family, where they can lead a happy married life. If the perpetrator is a family member, fear of relationship breakdown and fear of getting blamed. Trust issue, not having a trusted adult in their life for whatever reason they may have. Also, child feeling may not be believed because in the past they've disclosed something and parents took it lightly, or the carer took it lightly, so they're too afraid to say it again. If the perpetrator is somebody very respected or highly looked upon, for example, like a religious leader, a teacher, or a father figure, in many cases, if children witness domestic abuse growing up, they will not tell their mother. They're thinking of protecting their own mom, because they can see, years of trauma their mom went through. So therefore, they're not going to disclose. And I got many cases like that currently I'm working on. Lack of understanding of child sexual abuse. It's not always physical. There are many other factors, ways child can be sexually abused. Some children have intimidation by male member of the family, feeling very uncomfortable, but find it very difficult to express. When parents do not talk about sex in general to their children at all, so when a child sexually abused, they will not understand the difference between appropriate and inappropriate touch, therefore won't feel there is a need to tell somebody about it. Next slide, please. I'm going to share a case study I was involved with. So initially it came as a disability hate crime to me. But when I went to the household, mom disclosed the young person been raped by a family member, and she made me promise not to tell anybody. And as you can imagine, it's a safeguarding issue. I had to tell somebody. So they put me in a very difficult situation. Obviously, I could not keep it to myself. I had a duty towards this young person, and it was a safeguarding issue. So I told my manager and expressed, if the family found out, my reputation and trust within the community would be at risk. Because at the time, I was also working as an interpreter as well for the family law court. So he played a very smart, and he learned much as he can about the culture, religion, the family belonged to. So we planned a joint visit. He stood away from the doorstep and asked the client if he was okay for a male colleague to come in with me. Then he greeted the family in their own language. Then he was very modest, the way he conducted the whole interview with the family, kept saying, I understand it might be very difficult for you, to talk to a male member. This is not culturally appropriate. On the first visit, my colleague gained the family's trust, and the mother actually disclosed directly to him what happened to her daughter. Initially, they did not want to press charge again. against the perpetrator, they had lots of worry, like, this will bring shame on the family. What if the media or the community finds out? Will she be able to get married? Fear of breaking relationship because the perpetrator was a very close family member. After some support session, family was ready to report. We spoken to the police, gave the cultural and religious barriers. So police were very accommodating. They only sent female officers to take statement. A few days later, I had the rapist on my doorstep. As you know, Cardiff is quite a small community and everybody knows everyone. So I was shocked to see him. He wanted me to encourage the victim to withdraw the charge. And I told him if he came again, I would call the police. And I couldn't share that information either with my husband. If he found out, he may not let me support the family because there's lots of reasons, my safety, my reputation, and so on. So I had to tell somebody in my family, if you see this man again, you need to call the police. So at the time, my eldest was 20. So I told him and I said, if you see him around, please call 101 straight away. I told my manager and I told the police at a later stage about this incident. So sadly, the victim had so much pressure from the family, seeing the impact the family is going through and relationship breakdown. So she decided to withdraw the charge against him. Often I hear often I hear professionals are saying it's hard to communicate or engage with ethnic minority communities. It's not always the language barrier. We as practitioners sometimes have certain unconscious bias which prevents us from engaging. So as you can hear from this case study, my manager did not have language skills. All he did, he greeted the woman with, in her language, and he maintained modesty because the family were from Muslim background. So it's just little effort we can make to engage with the ethnic minority communities. Next slide, please. When we were conducting the project, and this is some of the recommendation we had from the focus group and the consultation, to translate the booklet and research into key community languages in Wales, awareness session in different language cross-community groups, workshop giving in a community members a chance to discuss issue in a very informal setting, campaign to tackle some of the cultural norms using various form, social media, campaign and posters, train community champions so they can be the eyes and the ears for the community, and trained trusted professionals who will also be equipped to deal with such issues. Report and support. More info on how to report once disclosed, and have the support system available for the whole family, because once it's reported, it's not just the victim suffering, the whole family unit suffer with the victim. So we need a holistic approach to support the family. All service provision should have key safeguarding officer who understand different culture and religious needs. Place of worship should have policies in place to be made compulsory, just like they have liability and building insurance. Currently, I'm not sure if place of worship do have safeguarding policies in place. Peer support for young people and the parents of victims, more representative, and visual image in the toolkit. Digital skills session for parents so they can report online. Next slide, please. Thank you. We are pleased to say we have the booklet available in 12 different languages. And recently we delivered the event to the community and professionals. And I have shared the link in the chat function. So you can have a copy of the booklet. And it's really easy to read, for ethnic minority communities, and we were very careful with the terminology, and we put all the barriers there and all the links of other agencies who, where they can get support from. So it's a really good booklet to have. Next slide, please. National Action Plan, Preventing and Responding to Child Sexual Abuse. In 2020 and 21, that's when Welsh Government commissioned East, Stonewall, Cymru, Learning Disability Wales to work with Stop It Wales Now and Lucy Faithfull Foundation to adapt and develop the resource to meet the needs of the Black, Asian, ethnic minorities, LGBT+, and learning disabled children and parents and carers. The information is available in English and Welsh with additional 12 languages I mentioned. Next slide, please. Last Tuesday, we launched that. Many parents from very diverse background attending the event, and we had professionals who work with ethnic minority community attending the event. And as I said, one member of the attendees was very tearful and stayed behind after the event and disclosed, and we gave her advice, and we're going to support the family now. Next slide, please. Thank you. Are you ready to bring change in Wales? We are actually looking for people who can raise awareness in the community. Interestingly, Yasmin said we need to work with men. I would love to see some of the male members of the community coming forward to go through that training. By having this training, you can pick up signs and symptoms of child sexual abuse and develop confidence in talking about this sensitive subject, which normally we don't talk about, and increase safety and resilience in your own community. So if anyone interested, or if you know anyone, please, send them my way. I will leave my contact detail in the chat function. Next slide, please. Ways forward. We need to continue to work with Stop It Wales Now and other agencies across all sectors, across Wales. We need to raise the awareness about sexual abuse, and it's not acceptable at all. If the child is not comfortable, this is something is very concerning. East as an organization, we work very closely with BAME community. Over the years, we have built good relationship and trust within the community that we work with. But Stop It Now are the expert on this field, and we need to continue work with them and working relationship and educate the community and practitioner to provide appropriate service to victims of sexual abuse. The focus group we conducted had already started discussion in our community. I've got quite a few parents coming forward saying would be very keen to take the training if we provide it in different languages. So that's really positive. We can build on those network and links, as well as the awareness we have already raised in the community, to work in partnership and take some of those recommendations forward as well. And thank you for everybody to listening. And if you have any question, please let me know. Yeah, we all need to come together and keep our children safe.
Thank you for that presentation. We do all need to work together to break down barriers in order for everybody to be able to access services equally. And if anybody is interested in becoming a trainer, I'm sure Fatiha will post something in the chat, if you wouldn't mind, so that we can contact you, and we'll again share that on our website as well to see if there's any interest. So if anybody is interested or knows of anybody interested, please pass on the details. Thank you so much for that presentation. I haven't seen any questions pop up in the chat, and I know you've got a dash down to Swansea now as well.
Yes.
So if there are any questions, we'll forward them to you later, if that's okay, if anything comes from this. and if not, we'll move on to our next presenter. So thank you again.
Thank you. All the best.
Take care. Bye. So our next presenter is Zahra Munsif, and again, apologies if I'm not pronouncing that properly, from Bowser, who is the locality manager in Cardiff, and she's going to be talking to us today about sexual violence in BME communities and the complexities around reporting. Thank you, Zahra.
Thank you, Joanna, for that. So my name is Zahra Munsif, and I, like Joanna said, I'm the locality manager for Bowser, and I manage the domestic violence services in the Cardiff and Vale area. And one of the main services that we have in Cardiff is the RISE service. And that's where we're in partnership with Llamai and Cardiff Women's Aid. So the three organisations have come together, and it's created what's called RISE, and that's where we provide the specialist support and advice that we have as Bowser, a lead organisation working with BME communities, focusing on forms of abuse such as honour-based violence, female genital mutilation, forced marriage, and that partnership with Cardiff Women's Aid, where they are specialists in domestic violence as well, and partnership with Llamai, where they're specialists in relation to homelessness and the youth. The three coming together, it's a holistic approach, and there's recovery programs as well. So for the women that are high risk, we have refuges across the city. And for those that are not necessarily high risk, but still need that support around domestic abuse and violence, we have a community team who will provide advice and support and advocate for women and girls who need support around understanding and becoming more aware around domestic violence and the issues around that. Knowing about healthy and unhealthy relationships, practical support, like Yasmin said earlier on, more often than not, there are issues around housing, there are financial issues, there are issues with legal matters, be it because of family or divorce or immigration issues. So within Cardiff, that is pretty much the support that we provide. And then within Bowser itself, we then have BME specialists in Cardiff and Vale and in the Cwmtaf area as well, who are working in the community, working with other partners and providing that support for communities who are struggling with not only domestic violence, but just not knowing what services are out there, not knowing what it is that they are entitled to and how they go about accessing those services and those support agencies and organisations. So it is about multi-agency working, and it is about making sure, in particular, BME women and girls are represented, that they're advocated for, especially for those women who are very vulnerable and need that advocacy in order to access the support that they need for themselves and for their children. I'm just going to share my screen with you, and hopefully technology won't fail me, and you will all be able to see my presentation. Joanna, can I just ask you to confirm if everyone can see that?
Yeah, that's fine, thank you.
Perfect, thank you very much. So the presentation today, I will be focusing on sexual violence in BME communities and the complexities around reporting. And like I said, my name is Zahra Munsif. We have a number of offices throughout Wales. We are a pan-Wales organisation. So our head office is in Cardiff, which is in Cardiff Bay, and it's lovely because we have the waterfront as our view. So I've booked my desk in the office in the summertime. And then we have offices in Merthyr Tydfil, Newport, Swansea and Wrexham. So if anyone needed to contact us, info@bowso.org.uk. So generally, issues faced by BME victims of abuse. There are a number of issues that BME victims of abuse will face prior to being victims of abuse, during the process, and indeed afterwards as well. So the list that I have here isn't too exhaustive. However, there are some points that I'm going to focus on. But as you can see here, we've got some issues here. So socioeconomic constraints, language constraints, housing, immigration status, BME women being ostracised, that social isolation, a lack of understanding and knowledge of BME issues by agencies, a lack of knowledge of welfare benefits by BME women, managing diversity and cultural religious needs, and a lack of confidentiality, empathy and support. Now, this has come from conversations that we have had with survivors that we have supported in the past and are currently supporting. This has come from the workforce itself and some partner agencies as well. Most of the staff in Bowso are from the community. So they are BME support workers themselves. So that lived experience is very, very valid. And that lived experience is what it is that we have been able to put across when we are representing survivors who we are supporting. Language constraints is probably one of the most obvious issues that BME people face, and BME women and girls of abuse will face. It's something that we as practitioners, something that we as services and agencies are much more aware of. We're all able to use interpreting services. So there's the big word, there's language line, there's WITS. And within Bowso itself, we have our own interpreting service where we have close to 300 interpreters that we are able to use if we have pre-arranged appointments with our survivors. We just need to understand that it's not a case of making sure that, you know, this woman speaks Urdu or Punjabi or she speaks Arabic or Chinese. We need to make sure that we get the dialect correct as well. And that is something that's really, really important because, for example, I myself am of Pakistan origin, and whilst I speak Urdu and I speak Punjabi, I'm from the Punjab. However, there are going to be Pakistanis from Pakistan who aren't from the Punjab, and so they don't necessarily speak Urdu and Punjabi. They are going to be speaking a very different language. So they'll probably speak Hindko or they'll speak Pashto. And if they do speak Punjabi, the dialect may be a little bit different. So we just need to make sure that when we do have interpreters for our service users, our patients, our clients, whatever it is that they are, we need to make sure that we get the language right, but we get the dialect right as well. And also, there is much more awareness now. If we are working with a BME female victim of abuse, more often than not, if you're phoning the big word or language line, you don't have a choice as to who the interpreter is going to be. It could be a male or a female. And if it is a male, we definitely need to establish, is that woman comfortable speaking to a male? He may not be there face to face, it may just be over the phone, but it's still really important that we bear that in mind. And if you are having face-to-face interpreting sessions with service users, just be a little bit mindful of using interpreters who could possibly be from the same community, because that could be a big barrier. That could be the biggest barrier for them being able to disclose, knowing that this person is from the same community. You know, we go to the same, our children go to the same school, we go to the same GP surgery, we go to the same place of worship, we're in the same circle when it comes to social events, etc. Housing and immigration, these are big barriers as well, and they kind of go hand in hand. If I, as a migrant woman, am in the UK and I am on a spousal visa, I, as a practitioner, will be able to submit an application to the Home Office to get that woman 3-month stay, where she is then able to address her financial issues. She's able to address her housing issues, and then after those 3 months, just before it's about to expire, she can then apply for indefinite leave to remain, and that will be all in her own right, and that will be as a victim of domestic abuse. So the issues around finances and housing and being able to gain that confidence and that independence to live a life, one without fear of abuse, but one of freedom, it's applicable to those that are in the UK on a spousal visa. However, if I'm here as a woman who has no spousal visa, I'm here as a student, or I'm here as a visitor, or I'm here on a work permit, or I'm here as an asylum seeker and I've got refugee status, that application, that DDV application, which a practitioner would submit so the woman can stay here in her own right for 3 months, isn't applicable to me. And there is a large majority of women who are in the UK and do not fit that criteria. So when we think of migrant women who do not have secure immigration status, it's like a domino effect. If you don't have that immigration status, you don't have the finances, and then you don't have the housing, and then your children are able to access school, and then it's a bit of an issue accessing health and so on. So things need to change there, and it's about making sure we're getting that support and that advice for that woman so that she is able to secure that immigration status, and she is able to secure the finances for herself and her children, so that she is then able to go on and live that secure, safe life. Being ostracized and social isolation, this is something that is an internal and external barrier. It's internal from within, and if we have BME women who have either been born and brought up in the UK, or we have BME women who have come to the UK from abroad. And if you are living in a home where you have an extended family around you, either living under the same roof of you, or living on the same street as you, or just around the corner from you, and it is very much about family, but within that family there is a lot of abuse, you are going to be isolated and ostracized from within that family. And that is something that is only internal. That is something that is only you and that family will know. And if I, as a BME woman who doesn't know about services that are available to me, I am not going to know that I can dial 101, or I can call BOWSO, or I can call RISE, and I can call EAST because the children are being affected as well. So that social isolation comes hand in hand with that, because being abused and then being ostracized internally will also lead to, well, no, you can't go out to learn English. You can't go out to take those driving lessons, or join community groups where women get together and they have IT lessons, or they discuss have coffee mornings, for example, or yoga in the park, or dancing, and all of these wonderful organizations that are for BME women and children and the youth. That isolation is going to hinder that woman to be able to get out there and know about the services that are available to her. And comes hand in hand with that a lack of understanding about the welfare benefits. Us as practitioners, we know that, you know, there's universal credit and there's housing benefits, but we have to keep ourselves updated on that. We have to keep on going to the Department of Work and Pensions and being in contact with our colleagues about any updates and making sure that we keep ourselves informed so that we can let our service users informed as well. But if you don't know what is out there already, and you are being controlled within the home environment, then you're not going to know. Managing diversity in cultural religious needs is something that I particularly relate to when it comes to refuges. So BAUSO, the refuges that we have are BME specific refuges. And that means something as simple as having a prayer room for a woman to be able to go into that room, to know that room is clean, it's safe. The religious books, whatever religion, whatever faith that woman is from, the religious books are there and they're kept in a safe and a clean space. She's able to sit there and just meditate or contemplate or lay her prayer mat out and pray and know that that place is sacred and it's clean. People haven't been walking in there with their shoes on. And then the kitchens, for example, that we have, you know, we have the vegetarian kitchens, we have the halal kitchens. Each woman is given her own set of pots and pans because, you know, it's important for a woman to know that these utensils, that, you know, they haven't been used to cook meat. So that is something that is very, very important. And that is something that we as a BME organisation are very aware of. However, unfortunately, that is not the case with a lot of refuges. It's not necessarily the case with us as practitioners when it comes to us going necessarily to people's homes and having that understanding around, you know, cultural and religious needs and requirements. So making sure we take our shoes off when we enter someone's home, you know, making sure that we are aware of there is a difference between halal and vegetarian and kosher. So it's just about being more aware. And for us as practitioners, it's important that we're not afraid of asking questions. If you're not sure, just ask. No one is going to be offended by that. I'm going to move on to the next slide. Expectations on a BME woman, and there are many, unfortunately, many expectations of a BME woman, and that's not just from being a BME woman in the UK, in a Western world. That's expectations on a BME woman and the extended family from back home, wherever that may be. That could be the Middle East, that could be Africa, that could be South Asia, that could be Southeast Asia. The pressure and the expectations on a woman to conform to what is acceptable is very, very difficult, especially when, you know, you are a woman who's been born and brought up in a Western society, and you are, you know, you're trying to figure out, well, this is where I am and this is what I do, but I'm also a BME woman, and there are expectations on me, and I need to conform. So when we look at things like lack of opportunities in the labour market, when we look at things like traditional versus Western dress, there are expectations on women from the South Asian community. For example, if we look at women from the South Asian community, there is an expectation that, you know, if there is a wedding, or there is a religious festival, or you've got family, friends, or you've got a possible proposal coming to our home, coming to the home, you need to wear traditional dress, and it has to be fitting, because if it is a proposal that's coming, then you need to look presentable. You know, the hair has to be nice, and the makeup has to be good, and the dress has to be presentable. So, you know, it's about keeping up with the culture. And whilst there are many, many beautiful and wonderful cultures, and I myself come from a wonderful culture where it is very vibrant, and it's about food and family and clothes and art and music, sometimes, you know, it can be very, very difficult to keep up with that culture. The expected role of a wife. You're not just a wife, you know, to your husband, you're also a daughter-in-law, and so the expectation of a daughter-in-law from the in-laws, the parents-in-law, the sister-in-law, being able to represent an entire family, you know, as the daughter-in-law, as the sister-in-law, as the wife, can be burdensome for some. Discrimination in a caste system. You know, this is something that's prevalent in the South Asian community in particular, and it can be discriminatory. If you are not from a caste system that is similar to mine, then, you know, you are seen as inferior, and that does have an effect on women. That has an effect on the proposals that they get. That could have an effect on them being able to progress in their education, in their careers, if they're lucky enough to do that. So that is something that is an issue. I know Yasmin touched on honour-based abuse, but it is an issue. It is an issue because if I, for example, refuse to get married to someone that my parents have said I must get married to, which is, as we all know, a forced marriage, it could end up very, very quickly turning into a case of honour-based abuse. It could end up in me being murdered because I have said no to my family or getting married to someone that they have decided is right for me. But I don't want that. And if I don't want that, or the other person doesn't want that, that is being forced upon me, and that is forced marriage. And that links to marital rape, because every time in that forced marriage, my husband has sex with me, it's marital rape because there has never been that consent. And if there's never been that consent, then any kind of physical relationship is forced. And forced marriage isn't just about you know, the female or the male saying no. We also need to consider child marriage, which, you know, it's prevalent across many continents. It's prevalent in the South Asian continent. It's prevalent in some European countries. If we look at America, there are still some states where child marriage is still acceptable. Gender inequality, lack of education, abuse whilst living in the extended family, extramarital relationships, these are all barriers and expectations and concerns that surround a woman. The extramarital relationship, if my husband has been forced to marry me and he doesn't want to be with me because he's actually with someone else, and he doesn't have the confidence, he isn't able to tell his family that no, I don't want to marry her, I'm actually with someone else, that extramarital relationships in some cases are bound to happen. Sexual violence in the BME community. Different communities understand and talk about sexual violence in different ways. In some communities, sexual violence is not recognised, especially in the marital home. This can discourage people within the community from disclosing the abuse they have suffered, also leading to a barrier to engagement with support services. There are some communities that are not willing or able and do not see it as appropriate to talk about sex, to talk about sexual relationships, to talk about appropriate sexual behaviour and inappropriate sexual behaviour, to talk about rape, to talk about abuse. And this is something that is cultural for many. This is something that is passed down from generation to generation. And it's well, this is how we do things. But times have changed, and having those conversations with our children, having those conversations, you know, parents between children, siblings, extended families, is really, really important, so that, you know, the older generation and the younger generation are educated and aware around sexual violence. Because not being able to have that discussion, making it taboo, is adding to what is already a very, very dangerous situation, where, you know, you have someone who is from BME community, it's a young girl or it's a young boy, and they are being sexually abused, but they cannot tell anyone in the family because that's not something that we do. Marital home, you know, I've touched on marital rape. You know, the idea of, well, he is your husband and he has a right to have sex with you whenever he wants to, and you cannot say no to him. And then having verses of the Quran or any other Abrahamic or non-Abrahamic religion, having verses of that religious book being quoted to you, it's all taken out of context. In no religion, in no culture, does it say it is okay for one person to force themselves on another, be it in a marriage, be it in a relationship. It is not okay. A woman can say no to her husband. And if a woman does say no, then the man must stop. But it's about making sure that we are having those discussions internally in our homes, and then we as practitioners are able to reach out and to educate and to highlight that, look, here in this country, it is illegal. And that in a marital relationship, it is wrong. You do have a right to say no, because there are still so many women out there who we are supporting even today who will say, but he's my husband and I can't say no. You can say no. You can say no. And it is rape. It is abuse. So that education really needs to start from home. Context of sexual violence in BME communities. So specific forms of sexual violence in BME communities, when we think of child marriage, it's still prevalent in South Asia, in Africa and America. Children from the UK are being coerced to travel abroad and forced to get married to family members. And I know we as practitioners, before the summer holidays, there is a lot of multi-agency working around children who are possibly going to be going back home to enter marriage or female genital mutilation, and it's about raising that awareness and making sure that there is safeguarding in place, and making sure that that person, that child, that woman, that girl is getting the support that they need. So if they need to be taken from that family home and put in a place of safety where they are advocated for on behalf of themselves, where they are supported, where we've got safety measures in place for them, then that is something that we need to do. Marital rape. A person's been forced to get married, has never consented, and therefore any sexual relationship is defined as rape. Women believe refusing to have sex with their husband is committing a sin for saying no. And it is down to us as practitioners to say, look, it is not a sin. You absolutely have a right to say no. And that mustn't be a barrier for them. Sexual exploitation. Women who are trafficked for the purpose of working in the sex trade are victims of sexual violence. And this is something that unfortunately, even in 2022, even in our country, is happening. And this isn't something about, you know, women being trafficked from abroad to the UK. It's happening within the UK as well, where women are being moved from one part of the country to another. Girls are being moved from one part of the country to another for working in the sex trade. FGM. Young girls are violated where genitalia is mutilated, having an adverse effect on their physical and mental health, as well as having an impact on their sex lives through to adulthood and having children themselves. This is still an ongoing issue. This is still something that we are having to raise awareness about, and this is still something that we are having to protect young girls for, even in this country, even in Cardiff, where it is still going on. And like I said, it's generational. There is nothing religious about this. There is no religion that says it is okay for you to cut and mutilate a girl. There is no medical reason for it, and there is no religious reason for it as well. It is cultural. It is cultural, and it has come down from generation to generation, and it is down to us as practitioners in BAUZO and other BME organisations to reach out to these generations, to reach out to the elders and to the youngers and say that this is mutilation and it is not okay, because it does have an adverse effect on women as they grow up. It has an effect on them physically, has an effect on them mentally. Worst case scenario, it can cause death. Sexual abuse from family members, risk of incest, rape by family members, and how this is handled internally and by external intervention. And we've talked about shame earlier on. Shame is a huge aspect when it comes to BME communities. The risk of incest and the risk of rape is absolutely massive. But shame for some is even bigger. And that is something that we need to cut through. And we need to say the issue here is that you have a young woman or a young man who has been raped, and they've been raped or they've been abused by a family member, and that is not okay. And that is something that we need to break down and be able to have those discussions so that BME people are able to comfortably be able to report and not make it a taboo and not make it something that they feel they cannot talk about because of the shame that they are going to bring on their families, extended families, in the community, in society. They feel they can no longer go to that place of worship or socialize in that community centre where people meet and so on. Barriers to reporting sexual violence, like I said, shame, the lack of knowledge. So we know about the government initiative around I only whistled at her, I only touched her, it's not okay. There is no I only. It's not okay. Blame, having the blame put on them, putting the blame on themselves. Family cover-up, ostracized by the community, fear of exposure in the media, fear of gossip, black magic, voodoo, jinns, exorcism. These are all very real, very tangible barriers for BME people to be able to report on sexual violence. The risk of being ostracized by a community if you have reported sexual violence from someone within the community or someone within the family is very, very real. And that being ostracized can have a massive effect on everything that young person or that woman or that man is going to do moving forward in their life in that area. The exposure in the media is also very, very real. And that could lead to death threats. It absolutely could lead to death threats. It could lead to worst case scenario murders, because that person has had that woman has had the audacity to report to the authorities that she has been raped or sexually abused by someone in her family or someone in the community. Fear of gossip, and that goes within any community. Black magic, voodoo, jinns, and exorcism. You know, there are a lot of communities, unfortunately, who feel that if a girl is saying no to getting married to someone, or if a young man or a young woman has come out and said that, you know, I'm from an LGBTQ community, that they are consumed. They're consumed. Someone's done voodoo on them. Someone's done black magic on them. There's a jinn, a spirit that's within them or surrounding them. And the way to cure that person is prayer. Or the way to cure that person is to get them married. And once they're married, they have children, they'll be fine. This is still something that, again, it's cultural, but it's come from generation to generation, and it's about us breaking that and saying, no, this is someone saying no because they don't want that for themselves. And you need to understand that and respect that. It's about that education, about that awareness. Sexual violence project, so activities, and I suppose for me, if we're looking at activities in order for people to be able to communicate and to get rid of the whole isolation, communities raising awareness events for victims and their families, building trust and support and guidance and signposting, providing a confidential and non-judgmental and safe space for disclosure, which is so important. And the outcome would be for the BME community have a better understanding of sexual violence, for families seeking help from professionals, which is something that BME communities need to be able to do, knowing that it's safe and it's going to be okay, and to help families to be able to cope better. That is the end of my presentation. I've got a couple of minutes left, so if anyone would like to ask any questions.
Thank you. I haven't seen any questions pop up in the chat. Is there anybody who'd like to ask anything? No? No? Okay. If there aren't, oh, Claire. Claire, do you want to come in?
Hello, apologies if you hear a dog barking. It's a bit noisy in my background. I was wondering how the benefit of having access to particular BME organisations is sometimes counteracted in a way by us pushing women to engage with some services where there isn't BME representation. I'm thinking particularly around some of the sexual assault services and some of the counselling services where there is massive underrepresentation of BME staff. So it creates a them and us of itself. So while you want to offer specific support that is really around the person's needs, we don't have in our NHS services, for example, the representation that we need. So I was just wondering, I had a specific issue with that with one person who was looking for a therapist who was a person of colour and was very specific that they didn't have to be exactly the same ethnicity as them, but they really didn't want to talk to, and I quote, another white therapist. Just wondered if you had any reflections on that, Zahra.
Yeah, this, thank you for your question, Claire, and this is a very real issue that we as a BME organisation are aware of, and it's something that's been highlighted even more since the pandemic, where, you know, we have seen a decline in the mental health of women and girls that we're supporting. So it's that being isolated at home, constantly living with the perpetrator, and it's just having a massive effect on the mental health of women and girls. And you know, a lot of them are from the BME community. We've been very lucky where we have been able to source some funding for counselling, and we've been able to source BME counsellors. So what I'm going to do is I'm going to put my email address in the chat, and what I can do is I can see if I can perhaps get in touch with the counsellor who is from BME background and see if she's able to assist. But it is a very, very real issue, because it is a predominantly a field where it's predominantly white men, women, and so there is that language barrier, there is that barrier of not understanding cultural differences, not understanding religious needs, not understanding, you know, where I'm coming from when I say I've been forced into a marriage, and being able to have that conversation and not explain where it is that I'm coming from, because having a BME person sat there listening to me, I know that person is going to understand, and it's really, really important. It is an issue. It is an issue, and it is something that we are aware of. It's something that we are as an organisation are trying to work on, but other than putting my details in that chat, I can, like I said, if you get in touch with me, then I can see if I can get a BME counsellor in touch. Hopefully, you can touch base with them and see if that will work. Hopefully, that's answered your question, Claire.
Thank you. Thank you.
Is there anything else?
Oh, Catherine, do you want to come in?
Hi, yeah, so I'm Catherine. I work in NSAF SARC, just down the corridor from Rice. Yeah, just responding from Claire, really, it's a really big issue and you know, something you're mindful of, and I suppose I'm thinking about as well as the barriers to people disclosing and the barriers to people seeking support, but we also maybe need to think about the barriers to recruitment as well. And yes, probably maybe something, maybe we'll have to have a conversation outside of this meeting to maybe have a think about that, because you know, that, yeah, getting somebody into the service is troubling enough, but then if we're not then doing things as well as we can when we actually do get them through the doors, then we're still failing, aren't we?
Absolutely, absolutely. And recruitment is a massive issue, isn't it? And it's something that has been highlighted, I think, through many sectors, and making sure that, you know, every ethnicity or every background or cultures, you know, there is that proper representation, and we just can't say that right now. We can't say that in health, we can't say that in education, we can't say that in our statutory services. Look, it is getting better, but there is still a lot of work to be done. And that comes under the whole equality thing, the whole and like you said, Catherine, that's another conversation altogether, isn't it?
Lovely.
Just putting my email address in the chat if anyone wanted to ask any other questions or anything like that.
Oh, that's brilliant. Thank you. And thank you. That was a really informative session. And you know, thank you for presenting and being present with us today. So if there are any additional questions, can they be posted in the chat, or if Zahra can be contacted through the email address that she's just posted. We're going to take an opportunity to have a comfort break now. So if everybody could come back in 15 minutes at 10:50, please. And then we'll be having presentations from Rory on LGBTQ+ and the Older People Commissioner's Office and Dewis Choice. Thank you all. Hi all, welcome back after the break. We're going to be commencing the second half of our learning event with a presentation from Rory White, who's a consultant and facilitator of LGBTQ plus survivors. And Rory's going to be presenting today developing support for and with LGBTQ plus survivors. So over to you, Rory. Thank you. Rory, your mic's not on. Okay, thank you.
I think we got it. Brilliant. Thank you. Okay, I'm just going to share a presentation and we can get going. Really hope this is going to work. Hi everyone, my name's Rory, my pronouns are they and he. I've been creating community-led support for trans non-binary survivors since 2018. Originally that was with LGBTQ Switchboard in Brighton, then in partnership between Switchboard and Survivors Network, which is Brighton's feminist rape crisis centre. I now run a small independent peer support project called Trust, and I'm the co-author of I Am Not Alone, How Can Survivor Services Meet the Needs of Trans Non-Binary Survivors? I do this on like a freelance and consulting basis and volunteer basis in some cases. And my day job is at National Survivor User Network, where I work on capacity building for grassroots groups that are led by people with experience of mental ill health. And my interests are survivor and lived experience leadership, LGBTQ community organising, and organisational and service design. So this presentation is going to be, it's not really like an LGBTQ 101 or a trans 101. It's going to be kind of some context on sexual violence as it affects LGBTQ communities, some thoughts on prevalence, type and impact, then exploring the diversity of experiences and barriers to support within LGBTQ communities, because obviously that's a huge range of people, right? And a huge range of different experiences of violence and responses to violence. I'm going to have a brief focus on how best to support trans non-binary survivors, because that's my particular area of expertise, and it's also an area that has been the focus of some like really polarized debate recently. And then I'm going to finish up with kind of an exploration of what services can do to support LGBTQ survivors, including breaking the disengagement cycle, which is where, because you don't work with LGBTQ people, no more LGBTQ people see that your service is for them, basically. The presentation includes links to sources and further reading and stuff. So after I'm done presenting, I can drop some links in the chat, but also I think this presentation will be sent out afterwards. So in terms of language, I usually use LGBTQ or LGBTQ plus when I'm speaking, unless I'm specifically talking about a community within the acronym. So if I'm talking about gay men, I'll say gay men. If I'm talking about trans people, I'll say trans people. I mean LGBTQ plus as broadly as I possibly can, while also acknowledging that there are people who are straight and cis and have societal advantages or experiences that LGBTQ people don't have. You'll hear me use the word cis, which might be a little bit less familiar. It just means identifies with the gender assigned at birth or not trans. And if my meaning isn't clear at any point, just drop a message in the chat. I might get back to you after I'm done presenting, just because I've got a lot of things going on my screen at the minute. This is a really useful link to Stonewall Cymru's glossary, which has some basic definitions and their Welsh translations. So about statistics, some of the stuff I'm going to present is going to be taken from various statistical things, but there aren't super clear statistics on prevalence of sexual violence in LGBTQ communities in the UK. Trans experiences of sexual violence in particular aren't well studied. I'll talk more about that in a minute. Some of the statistics I'll show here refer to domestic violence and intimate partner violence, and obviously that's, that can include sexual violence, but sexual violence doesn't always, and sexual violence happens outside of domestic violence and intimate partner violence. There's very little research into child sex abuse and child sexual abuse of LGBTQ people and LGBTQ survivors of child sexual abuse. And I try to use statistics appropriately and sensibly, and not for shock value. So I also use some qualitative research, which helps us to understand some of the nuances and the experiences of sexual violence. So first off, LGBTQ people experience sexual violence at an increased rate compared to straight and cis people. These statistics are from the Crime Survey England and Wales from the 2020. The sexual violence statistics broken down into sexual orientation, so lesbian, gay, and bisexual, and also heterosexual and straight, indicate that on all counts, LGBT people are at higher risk of sexual violence. Bisexual women in particular report particularly high levels of violence. There are percentages of estimated prevalence among kind of population. So, for instance, 0.7% of heterosexual men are estimated to have experienced any kind of sexual violence, compared to 4.7% of gay men, and so on and so forth. You see, I've highlighted bisexual women's experiences there because it's 15.4%. The CSEW doesn't report on trans status as relates to sexual violence. Smaller scale UK research indicates a really high prevalence of both DV and SV. The 2015 US transgender survey from the CDC found that 47% of transgender people that they surveyed were sexually assaulted at some point in their lives. I wouldn't compare that to the CSEW statistics because they're done using a different methodology, but they do really clearly indicate that trans communities are at a higher risk. It's just we don't have the level statistics or exploration in the UK, at least. Free to be Safe from Safe Lives, published in 2018, it shows that within situations of DV and intimate partner violence, LGBTQ plus people experience sexual violence and actually all other forms of violence at a higher rate than non-LGBTQ people. Not only that, but LGBTQ survivors of domestic violence have worse mental health outcomes compared to non-LGBTQ survivors. So we are twice as likely to self-harm or attempt suicide. We are more likely also to have experienced abuse at the hands of multiple perpetrators and historic abuse as well. So why is this? I can't really explain that in 5 seconds of a PowerPoint slide, but some possible things and factors are include the prevalence of risk factors for experiencing abuse, like homelessness, poverty, substance abuse, family estrangement, lack of specialist preventative support or support for survivors, and rape myths, so things that are commonly held as true or influence the way that people are able to get support. So beliefs like child abuse makes you gay, or trans women are predatory, women don't commit sexual violence, gay men are dangerous to children, all of these kind of homophobic, transphobic, misogynistic beliefs that we know, that rape myths aren't just kind of like these innocent sort of things that are floating out there. They have a huge material effect on who is considered to be vulnerable to sexual violence, who gets support, what kind of response they get when they disclose. It's really important that we understand these as rape myths and as things that we can actively combat in our practice supporting survivors. It's also the case that LGBTQ people experience some forms of sexual violence that straight and cis people may be less vulnerable to. For instance, sexual violence as related to anti-LGBTQ hate crime. So 17% of respondents in Gallup's 2021 LGBTQ hate crime report identified that as part of hate crime, they had experienced sexual violence. And sexual violence also factors into so-called conversion therapy. Gallup is the UK's LGBTQ anti-violence charity, and they do a lot of work on sexual violence and domestic violence as it affects. So Gallup asked almost 1,000 LGBTQ survivors of sexual assault whether at any age they'd experienced violence that was sexual violence that was intended to convert them to heterosexuality or to their assigned gender at birth, or to punish them for their gender or sexual identity. And almost a quarter reported that they had. This isn't a prevalence survey. It's not saying that a quarter of LGBTQ people have experienced this kind of violence. It's saying that a quarter of people who have experienced sexual violence, a quarter of those people who responded saying that they'd experienced sexual violence experienced it as conversion therapy. Those figures rise also depending on the particular identity of the person. So it was higher when the victim was asexual, non-binary, a trans man, or a trans woman. And that, again, reminds us that it's really important to think that sexual violence happens in different ways to different people in different parts of the LGBTQ community, or the various communities that make up group of people. To try and illustrate this, and to move us a little bit away from statistics and more into the realm of like thinking through how some of this actually works, there are these three scenarios. These are fictionalized, but they're based on experience working in this field. When I'm talking through them, I really encourage you to think about the specific barriers that these people might have in accessing the services that you are involved in delivering. So we've got Simon. Simon's family think that his gay identity is because he was abused in childhood. They're pushing him to talk about it with a counsellor who deals with unwanted attraction. That's code for conversion therapy. Now, as we've seen, conversion therapy can itself be sexually violent. Even if it's not, it can be incredibly damaging. Some of the barriers that Simon might experience through this experience might be distrust of therapists, family estrangement, maybe homelessness, and a difficulty kind of articulating the relationship between his experiences of trauma and sexual violence and his gay identity, his sexual identity. Tina. So when Tina went to the police about her ex-husband stalking her and her girlfriend, officers made racist assumptions and repeatedly called her girlfriend her friend. She left feeling that her identity as a bisexual Black woman was too complicated for them to listen. That thing about being too complicated is something that I hear a lot from a lot of different people, especially people who are positioned at some point like in the intersections of multiple oppressions. The idea that your identity, just who you are, is too complicated or kind of like not really mainstream enough to receive support and services is really pernicious. And then we've got Maria. So Maria is a trans woman whose ex-wife forced her to penetrate her with threats of outing if she didn't comply. They've now separated. Maria is only just beginning to identify what happened to her as sexual violence and doesn't know where to turn. So here we've got the fact that in UK law or in English and Welsh law, rape is defined as penetration with a penis. And, those kind of legal definitions can often sit at odds and feel really confusing for survivors who are from LGBTQ communities where forms of sexual violence can operate differently. And, they can operate differently as well outside of LGBTQ. An issue within the communities. We can also see kind of the question about like trans inclusion coming up here, and the question around barriers around safety in like single sex services and things like that. Oh, and the other thing that I think that scenario with Maria brings up is the different ways that LGBTQ people can be particularly vulnerable to different forms of abuse of power. This is what this LGBTQ power and control wheel tries to kind of elucidate. So it reminds us that there are avenues of control over LGBTQ people that are used by abusers that may not be immediately obvious if you're not familiar with the community or with the kind of things within those communities. So some examples might be restricting access to hormones or gender affirming clothes. It might be using kind of homophobic or transphobic systems against someone, saying, well, if you don't do what I say, I'll tell your family that you're gay. Or it might be about cutting off people's access to local, like, queer communities, which can often be quite small. And so that kind of like reputational stuff can be really, really important to someone's support structure. It might be also something about, oh, what was I going to say? Oh, yes, using like dismissing or invalidating someone's identity. So saying, you know, well, if you were a real lesbian, you would do X. Or maybe saying to someone, well, you're not, you know, you're not gay, you're not trans, you're not bisexual, you are what I say you are. So I'm going to look briefly just at a focus on trans and non-binary survivors. So, like I say, I've been working on this since 2018, but from 2020, I co-ran a group based in Brighton's Feminist Rape Crisis Centre Survivors Network. It was open to all trans, non-binary and intersex people who wanted to come, regardless of their gender identity or the fluidity of fixedness of that identity or birth assignment, legal gender, whatever else. We didn't ask people to describe or justify their trans and non-binary identity, and this is quite different from a lot of other services. One group participant told us, you know, usually male or female is the first box that you tick. So when we took that away, it was really interesting who came and what they felt when they were there. And yeah, you can read more about that in the report. I'm going to kind of share some highlights, but it's not the whole thing. So some of what we learned about how sexual violence impacts trans and non-binary people. Well, first thing, experiences of trans and non-binary people chimed with the experiences common to most survivors, whether cis, trans, non-binary, otherwise. People talked about not initially recognizing their own experiences as assault or sexual violence. They talked about not feeling believed, supported, or validated, and by non-specialist services, especially like healthcare services and the criminal justice. That said, it's also the case that some trans and non-binary people have experiences of and responses to sexual violence which are different from those of cis people and which require different support. So, for example, not fitting into gendered services, not just because of one's own gender, but also because of the gender of the perpetrator. And services which presuppose a cis, straight, male perpetrator can exclude many LGBTQ survivors, not just trans and non-binary people. Survivors also noted a lack of understanding around what kinds of violence were experienced, how the survivor identified or presented at the time, and a recurrent form of transphobia in which transness was seen as a consequence of the trauma. And again, that's actually a thing that comes up for a lot of LGBTQ people, is this what I will call a rape myth idea that someone's sexual or gender identity is traumagenic. It's created by trauma. It's maybe even a maladaptive response to trauma. Doesn't really happen. Trans and non-binary experiences are not homogenous is a really important thing. So one trans feminine interviewee said that they would ideally like a space just for trans people who are assigned male at birth, while a trans man interviewee indicated that he really wanted to talk about sexual violence in a space just for men, but including cis men. So he would have been comfortable with cis men being in that space. Trans non-binary identity is very unlikely to be the only vector of oppression that people are dealing with. Race, faith, disability, poverty, age, and gender all got named as factors that made people more vulnerable or excluded them from services and meant that they weren't well served when they did access services. One thing that I really want to bring up is homelessness. So especially in regards to the trans community, but the LGBTQ community as a whole has a higher rate of homelessness, but the trans community, a quarter of trans people in the UK will experience homelessness. And the final point that I want to really pull out from the report that I think is really important is that people found expressing their trans identity to be part of healing from sexual violence. People who had attended the group identified it as a space where openness about gender identity enabled them to share more about and be supported regarding their experiences of sexual violence. I love this quote from an interviewee: "What I needed and still need is the acceptance that what happened was real and the ability to learn how to rebuild a life. That feels similar to the process of learning to express gender fluidity." So gendered spaces and specialist support. The Equality Act 2010 allows, in limited circumstances, exclusion of trans people from some single-sex services. I'd like to take a moment to ask you to reflect on how that feels for transgender survivors of sexual violence. It doesn't mandate or require this exclusion. There's no evidence that the inclusion of trans people is a risk to cis people in those services. What there is evidence of is that trans people experience sexual violence and have very limited access to support following it. Practice for single gender spaces is that they should be explicitly inclusive of LGBT and trans non-binary survivors and actively welcoming in practice with outreach plans for including trans service users. LGBTQ people may also seek out specialist support in LGBTQ-only spaces and groups. The provision of specialist support shouldn't be used, however, to exclude LGBTQ survivors from general services or from whichever single-gender services they choose to access, if they do. Non-binary people may wish to access single-gender services based on shared experience or identity with other people in those groups. So, as an example, I'm a non-binary transmasculine person. I've accessed men's spaces. I feel comfortable in those spaces and they've been welcoming to me. Other non-binary people may not wish to engage in any single gender spaces and would prefer alternatives. Language for and facilitation of these spaces should be carefully considered in order to support non-binary people to access whatever spaces they feel best supported in without having to minimize or hide their non-binary identity. And something that I really want to encourage people to think of is that the existing survivor support sector's feminist history and practice gives it so many tools to be a really strong ally to trans and non-binary people, because ultimately what we're talking about here is agency and empowerment and respecting kind of self-determination. Trans and non-binary people want and deserve to give and receive support in spaces which commit to a trauma-informed anti-oppression practice, and where the empowerment of survivors is seen as key to healing. So what can services do to support LGBTQ survivors? Services who know this stuff is really important. And for that, you need LGBTQ-led training consultancy, especially kind of long-lasting partnerships. So organizations such as Stonewall Cymru and Glitter Cymru, the latter of which offer BME LGBTQ allied training, are really, really good to go to with requests for support. A well-funded range of options, which include immediate crisis support, long-term mental and physical health support in the aftermath of violence, community and peer counselling, LGBTQ inclusion in wider spaces, and LGBTQ-specific spaces in which to build safety and community. Ensuring support is not conditional or seen as conditional upon reporting to the police is really important. LGBTQ people are very unlikely to report even serious incidences to the police. Survivor leadership. Being able to make decisions about the support you get is key to the empowerment model of supporting sexual violence survivors. And when you support LGBTQ survivors well, it may mean changing some of the stuff that you do, right? Changing some of the language around who perpetrates and who experiences sexual violence. The people to lead you in those changes are going to be LGBTQ survivors. I'm conscious of time. I'm just gonna skip through. You'll get this. I think it's more important that I talk through this bit rather than yeah. So the disengagement cycle is this idea that if you don't support many LGBTQ people, then you don't build up the reputation and the skill set and the knowledge that you need to do that well, and you also don't build up the trust with the community. And then as a result of that, you continue not to support many LGBTQ survivors. And my kind of position on this is that you can't really intervene just in this little bit about not supporting many LGBTQ people. You've got to pick one of the two, either that LGBTQ people don't hear about or trust the service, or that the service has a lack of specialist knowledge and low evidence of engagement. And you've got to focus on one or both of those with kind of practical interventions. Interventions for that lack of specialist knowledge and evidence involve training and knowledge sharing partnerships and collecting data sensitively. Stonewall have some really useful things about how to sensitively and appropriately collect data on LGBTQ identities. And in terms of building trust with and relationships and communication with LGBTQ communities, word of mouth is incredibly important. Connections with community groups. LGBTQ communities are often really, really active and have a lot of like internal structure, if you like. So being able to tap into that and like acknowledge that kind of community strength is really important. Partnerships with LGBTQ organizations, policy work. I think I put that, I think by that what I mean is like having a really good like trans non-binary inclusion policy or something like that. Recruitment from the LGBTQ community. And if you're going to recruit from the LGBTQ community, you also need to think about your EDI policies, your support at work, maybe your LGBTQ staff network, transitioning at work policy. And specialist roles and services. Often LGBTQ people want or feel safest in specialist spaces where it's like an LGBTQ only space, or more specific, like a gay men's group or a lesbian group or something like that. And I'm going to finish up with some ideas about supportive outcomes for these three kind of scenarios that we looked at earlier. So we've got Simon, who, after leaving his family home, finds support from a youth homelessness charity, which has a peer support group for LGBTQ survivors. And this feels much safer than one-on-one support, given his experiences with conversion therapy. He gets involved in campaigns to ban conversion therapy. There's something really important there about like activism and community connection, and also the fact that not all survivors of sexual violence will find support in like specialist survivor services, if that makes sense. Knowledge about how to support LGBTQ survivors is incredibly important for everybody who is working with LGBTQ people because of the prevalence of sexual violence and other forms of violence within the community. We've got Tina. Tina gets support from an IDVA who helps her to access support and complain about her treatment by the police. And importantly, her girlfriend plays a really important part of her support structure and safety planning. There, I think, is the recognition that relationships are not risk factors, and they are, in fact, sources of like deep support, or can be sources of deep support, and that LGBTQ relationships should be kind of treated in that way. And Maria gets in contact with Leah, a trans advocate based in an LGBTQ charity. Leah speaks to the local women's rape crisis on Maria's behalf to gauge how welcome Maria would be, and accompanies her as a supporter to their drop-in. So something here about the cooperation between LGBTQ specialist charities and survivor support charities, which unsurprisingly, considering I've worked in those kind of corporations, it's really like dear to my heart. I think there is an enormous amount that can be learned from those kind of cooperations. And I'd also say that my example here about accompanying Maria to the drop-in is based on what we heard from a lot of trans survivors, that they wanted to have a friendly face when they were first accessing services, that they were unsure whether they were safe or not. They wanted to know that they wouldn't be like alone. And I think that's really, really key. And that kind of flexibility feels really important. Yeah. The other stuff I've got is a couple of recommended resources from Gallup, from Saba Chowdhury, who's written this amazing book on supporting trans people of colour. Supporting Trans Survivors of Sexual Violence by Valentina Carte and Sally Reimer, came out, I want to say 2016, but it was originally, the research was done in Brighton with Survivors Network. And some Welsh-specific organisations. We've got Trans Aid Cymru, who are a trans mutual aid group, Glitter Cymru, who are an LGBTQ BME group, and Stonewall Cymru. And that's the end of my presentation. Thank you very much. Slightly over time, but happy to take any questions if you've got them.
Oh, that's fine. Thank you, Rory. Are there any questions? I haven't seen any pop up in the chat, but if there is anybody who's got any questions. Thank you, Ali. Thank you. I don't think that there's anything, so I'd like to say thank you, Rory. I found that really, really informative. And I think that, you know, that the whole of the everybody here today would have also found it really informative. How we can ensure that you know, we do develop support that's giving equality of access for all LGBTQ plus survivors, and how we can work with specialist services to ensure that the more mainstream services are accommodating, and how we can all work together. So thank you very much. So we'll be moving on now to our next presenter, who's Andrea Cooper, and Andrea is the Deputy Older People Commissioner for Wales, and the Older Person Safeguarding Lead within the Commissioner's Office. So thank you, Andrea, and over to you.
Thank you very much. Hi, Bordar, everyone. Yeah, I'm actually the Safeguarding Lead, not the Deputy Commissioner, so just to explain that. But yeah, I'm delighted to be here today. Thank you very much for the invitation. So yeah, my name is Andrea Cooper. I work as the Safeguarding Lead, which means that I work on the Commissioner's priority of ending the abuse of older people within Wales. So next slide, please. So ending the abuse of older people is one of 4 key priorities. And if you look at these priorities, you will see that they are sort of interlinked. They're not separate or discrete in that sense. So, for example, we know that ageism is a big contributory factor to the abuse of older people. And we know obviously that older people, or people generally, can't age well if they're experiencing abuse and neglect. So all of these areas sort of impact one upon the other, but they each have different leads, and we all work collaboratively and together. So next slide, please. So just some statistics really that I've sort of put together just to give an indication of what we know of levels of abuse. But I have to say that these statistics, they're probably lower than they would be in some respects, because we know that the abuse of older people is very much underreported for all sorts of reasons. Older people are felt to be at increased risk of abuse because of illnesses like dementia, or because of factors like loneliness and isolation. But obviously that impacts then upon their ability sometimes to report situations of abuse. And if you are dependent upon somebody for your care, and that person is the person who is abusing you, then you can be very frightened perhaps, and very reluctant to disclose that abuse and to seek help. We know that there's also a big issue in the fact that older people don't always know where to go for help. So, you know, sort of a lot of people, even if they're experiencing abuse, sometimes they don't recognise it as abuse, but they don't know what services are out there. So they don't know where to go or who to contact for support. And, you know, as sort of highlighted in many of the excellent presentations that have been sort of already undertaken today, you know, older people are not a homogenous group. And so, for example, we know that particular older people, such as those from BME communities or LGBTQ plus communities, the rates of disclosure are even lower amongst those particular people for all sorts of reasons, such as anxiety about shame or guilt, or, you know, just not knowing where to go for support, just not knowing what services are out there really. Next slide, please. So sexual abuse, we know that, you know, that this is a particularly underreported form of abuse for older people. There's very few academic studies highlighting the sort of prevalence rates of sexual abuse amongst older people, and the sort of 2 main data sources are also problematic. So those are the police recorded data. Well, older people don't necessarily report sort of sexual violence and sexual crimes to the police. You know, they might worry, for example, that they're not believed, they won't be believed. It's a common sort of myth that older people are asexual, so they might worry that if they took those sorts of concerns to somebody and raised them with anybody, that they would just be dismissed, or it would just be assumed that it could not have happened. The other sort of data source is the crime survey for England and Wales, which again is problematic at the moment because there's an upper age limit on that data. At the moment, the crime survey doesn't record data for people over the age of 74. Sorry, so if you happen to be 75 and experiencing any sort of bowel SV, then your sort of experiences wouldn't be represented within that data. That situation has been addressed, and following calls from the Commissioner and others, that there isn't going to be any sort of age limit on the data from 2023. But at the moment, it doesn't help us to understand the levels of sexual abuse amongst older people. We certainly know that it happens. We have anecdotal evidence of it happens. And sometimes, even if it has particularly happened amongst people in older age, they can still be affected because of sexual abuse, way back in time. So, it's historical, but it's still very much a feature of their day-to-day lives in the present. Next slide, please. So the Commission has been very concerned about increases in levels of abuse throughout the COVID-19 pandemic, because we know, for example, that usual monitoring procedures, perhaps services have been reduced or withdrawn. So, that there's increased risk for people in that respect then, because the usual sort of ways of identifying that abuse may not be recognised. We know sort of unpaid carers, they do fantastic jobs, but carers report that throughout the pandemic they've been pushed to breaking point, actually, because they've taken on more caring roles and responsibilities, and sort of typical services like daycare or respite, for example, have just been closed down because of sort of worries about infection and sort of safety, and it really just has pushed people to the point sometimes where they just haven't felt they've been able to cope. So next slide, please. In response to these concerns, what the Commissioner did was set up an action group to look at stopping or preventing the abuse of older people within Wales. And there are at the moment in excess of now, I think, 30 different organisations who are part of this group. So they are both sort of statutory, non-statutory, health, social care. There's a steering group, so the action group, the work of the action group is led by a steering group, and there are older people who are part of that steering group. And if we move on to the next slide, the steering group an action group have together worked collaboratively to develop a kind of strategy for tackling the abuse of older people in Wales. So there's 6 sort of levels to this strategy that we have been and continue to work on. And what I thought I'd do today is just sort of talk through some of the work that we've done so far, some of the ongoing work that we have planned for the future, really. So next slide, please. Yeah, so if we look at public awareness, as I said, I think the levels of awareness of the abuse of older people are very low. I mean, from a personal example, I was working several years back in a sort of sixth form college, sort of doing some lecturing around adult protection and child protection, and it was really striking at the time that the students who were sort of 16, 17, they all knew quite rightly about issues of child abuse. That's exactly as it should be. But it was quite shocking, really, because they had the majority of them had no kind of sense of the fact that older people were abused, and they were quite open about that. And it just got me to thinking, really, about the sort of extent of this problem. How do we get this information out there? And I think, that sort of the public awareness raising strand has a number of elements, really. I mean, in one respect, it's raising awareness amongst older people themselves of what constitutes abuse, so that they know that some things perhaps, are not acceptable, but they might have actually tolerated certain things for many years, but that it is actually abusive behaviour. And it's also raising awareness of the sort of services that are out there as well. So during the pandemic, we at the Commissioner's Office, we generated a leaflet, a Get Help Stay Safe leaflet, which was for older people and community at large, really, just for everybody, to sort of raise awareness of the signs and indicators of abuse, and also to enable people to know where they could go to get help, what sort of services were out there, what was available, and what might help keep them safe, really. So that leaflet covers all sorts of abuse. Next slide, please. And the Commissioner has also sort of commissioned a number of pieces of research. The research that I refer to here is around support and services. So we know, for example, that levels of awareness amongst older people of services is quite low, but we actually arranged for a mapping exercise across the whole of Wales to see what sort of services were out there for older people who were at risk of or experiencing abuse. And what we found was that, you know, theoretically that there's quite a range of services, and theoretically these services are all age services, but there are a lot of barriers to uptake by older people, and there are all sorts of reasons for that. So, for example, sometimes services probably unwittingly don't advertise themselves in such a way as to show that they're also available for older people. Obviously that's not all services, but it's just one example of an area to be worked upon, really. There are of course examples of good practice, and one of the things highlighted in the report is the importance of relationships, really. So that working with older people is really, really important for practitioners to build relationships with them, and to really sort of work closely with them in sort of, you know, discursive ways over time to enable them to disclose their experiences and to seek help to keep themselves safe. The Commissioner also looked at the accommodation available to older people, and what she found, for example, was that there is very little specialist accommodation, and certainly my background in social work, you know, can sort of relate to that. Situations where, for example, older people needed to flee abusive relationships, and literally the only kind of accommodation available to them might be a residential home, which they didn't particularly need, certainly didn't want, but because of perhaps issues with mobility or access or whatever, we just couldn't find any other accommodation. And obviously that's something that really needs to be addressed to ensure that there's parity of service, and to ensure that older people have choices really around their futures, and are enabled to leave abusive relationships when they want to. Next slide, please. So yeah, I talked about research in the last slide. We've got a piece of research at the moment that we've commissioned, which is actually looking at the experiences of older men who are at risk or actually experiencing domestic abuse. Because recent ONS data shows that older men, for men in particular, as they get older, the risk of them being abused increases. So we've actually want to look at that, and to look at what the experiences of these men are. If they have experiences of services, what were those services like, and how we can improve this situation, really, because I think it is a problem, you know. We have to make sure that there is a big focus on violence against women, and we know that the highest proportion by far of those experiencing abuse are women, but that doesn't mean that men don't experience abuse, and we have to make sure that we have the appropriate services and sort of appropriate support available for these men also. Next slide, please. So the other sort of strand of the strategy that we've done quite a bit of work on is around policy and legislation. So I'm sure you'll all be aware of the recent kind of consultation on the Voucher SV strategy. So we've obviously worked quite hard in putting a response together for that, and we responded both as an organisation and jointly as an action group, really. And what we want to really make sure is that the voice of older people is heard in the refresh strategy, and that older people, you know, that they're given a far higher priority in terms of support and services. And also the Welsh Government action plan on preventing the abuse of older people is sort of very welcomed. We're waiting for that to come out, because this is such a big area and something that we really want to tackle and make sure that those services are out there and that older people get the support they need and feel able to come forward and talk about their situations as well. So that's the end of the presentation. So thank you very much. Happy to take any questions.
Thanks, Andrea. There was an interesting comment by Rory in the chat that he's struck by how all the communities are marked by a clear lack of data and myths, and I think that's a commonality that's running through all of the presentations and the areas covered today. Are there any questions for Andrea? No. Okay, thank you. Thank you, Andrea, and thank you for presenting today. That I found that really informative, and it's really interesting to see what all the information and the research that's coming out of the Older Person Commissioner's office. So on to our final presentation of the day then. This is Elise Freeman, who's the Service and Training Development Lead for Dewis Choice. Giving a presentation on older victims, survivors of sexual violence and abuse. So over to you, Elise. Thank you.
Oh, hi, Joanna. Thank you. Is that okay for me to just share my screen?
Yeah, that's fine.
There we go. Has that come up okay?
Yeah, that's lovely. Thank you.
Oh, that's brilliant. Thank you. Yeah, so my name's Elise Freeman and I'm Service and Training Development Lead for the Dewis Choice Initiative, and we're based at the Centre for Age, Gender and Social Justice at Aberystwyth University. My background is I'm a Safe Lives accredited independent domestic violence advisor and a sexual violence advisor, and I've worked with Dewis Choice as a wellbeing practitioner in the past as well, supporting older victim survivors of domestic abuse, including those who've experienced sexual violence. So the Dewis Choice Initiative combines longitudinal research with a co-produced service, and this is a specialist service supporting older female, male and non-binary victims of domestic abuse and their family members. The initiative launched in 2015 and it examines the lived experience of adults aged 60 years and over who experience abuse from a partner, ex-partner and/or an adult family member. So older people are often overlooked as victims of domestic abuse and sexual violence. When they're included in policy and strategy, they're often homogenised as a group, which fails to recognise experiences of violence across the life course, which are diverse, including the intersections of race, ethnicity, gender, sexual orientation, gender assignment and disability with older people. And Dewis Choice research has found that there have been significant gaps in research into this group. So little was known about their experiences of domestic abuse, and much of this was framed under a banner of elder abuse, which had the effect of homogenising an extremely diverse group with a 30 to 40 year age span. There are significant gaps, as we've heard, in data collection for this group too. So until 2017, the Crime Survey for England and Wales only collected domestic abuse data up to the age of 59 years. As Andrea mentioned earlier, that age cap was raised to 74 in 2017, and the latest figures showed that 280,000 people aged 60 to 74 of age experienced domestic abuse in the year ending 2020. The upper age limit has now been removed, so we're waiting for those statistics for the older age group. But looking at that in terms of the referrals into our initiative, many of our referrals have been for individuals aged 75 to 85 years of age, so they wouldn't have been captured in previous surveys. There are also significant gaps in service provision. So domestic abuse services and responses have been developed based on an intimate partner, heterosexual model, primarily aimed at younger women and their children, and they're not always equipped to respond to the specific needs of older victims. There's also a low visibility and recognition of older people as victim survivors of domestic abuse, and this is within service provision and the media. Safe Lives Insight data in 2016 found that only 3% of older victims accessed high-risk IDVA services supported by the Marriott model. So they're really quite invisible across that risk, from low risk up to the high risk. And there's a lack of understanding of older people as victims of abuse from adult family members, again, which is often framed under a banner of elder abuse, although this falls within the definition of domestic abuse. So in terms of the support the initiative has offered, to date, we've provided intensive support for over 180 older people and their family members, and we've been able to follow their progress through our service for a period of up to 18 months and record the research with this group. All referrals are offered to engage directly with the research staff as well, and many of them do take that opportunity. So 74% of our referrals are female and 26% are male. The youngest client was 58, as we had a lower age intake of 55 for our specialist dementia project. The eldest was a 93-year-old who'd experienced physical and financial abuse from an adult child. Over 2/3 of our clients are aged 75 years and over. Half of our cases are adult family violence and half are intimate partner or ex-partner. A number of our clients have experienced abuse from both intimate partners and family members, either concurrently or across the life course. Over half of our clients have a disability, and the majority of these are physical and affect mobility. Not all of this group has needs for care and support needs, and those who do range from minimal support to requiring support more than once a day. And dementia has been a feature in 1/5 of our referrals. So older people engaging with Dewa's Choice have experienced the same forms of abuse and the range of severity of abuse as younger victims, including sexual violence. Older people supported by DEWIS have disclosed sexual violence, which has been recent in terms of in a long-term relationship and new relationships, as well as historic. So there have been disclosures of sexual violence early on in both current relationships and past relationships. In some cases, an older person feels able to disclose the sexual violence for the first time that may have happened 30 to 40 years ago, but it's still having a significant impact in later life in terms of trauma, depression, and anxiety, which really highlights the need to still offer routes to support. A small number of our older male clients have also disclosed recent sexual violence from intimate partners. And it's unusual for sexual violence to be identified at the point of a referral. So when working with older victims, often disclosures of sexual violence are made months into building trust with a practitioner. So looking at the prevalence, in terms of sexual violence in the older demographic, in line with the delay in the data collection on domestic abuse for older age groups, the crime survey for England and Wales did not begin collecting data on victims of sexual violence over the age of 59 until 2017. In police recorded crime data for sexual offences in the year ending March 2020, 2.4% of victims were aged 60 years and over. Local authority adult safeguarding data for Wales for the year 2018 to 2019 identified sexual abuse in 284 of the referrals for those aged 65 years and over. And as Andrea said, there's been very few research studies into this group, but a study of police data for the period 2009 to 2013 across 45 forces in England and Wales and Northern Ireland found that most victims of sexual assault who were aged 60 years and over knew the perpetrator. 26% of older victims identified the perpetrator as an acquaintance, 20% as a partner or husband, and 20% as a stranger. The majority of these offences were carried out in the victim's own home, with 21% carried out in care home settings. Researchers also highlighted gaps in knowledge around consent and criminality in the older age group. So, for example, marital rape did not become a criminal offence until 1991. So for older people who've experienced rape within a long marriage before 1991, this would not have been a crime unless they sustained a physical injury. A YouGov survey carried out in 2018 found that 35% of those surveyed aged 65 years and over did not think that non-consenting sex with a spouse or a partner was rape. There are numerous initiatives aimed at younger people around healthy sexual relationships and consent, but very little targeted at older age groups. So Dewi's Choice training with practitioners across the UK have found that some domestic abuse practitioners report reluctance to ask older victims about sexual violence. And this has in part been down to misconceptions that sexual violence is not a feature in older people's relationships, but also due to fears of offending or embarrassing an older person by asking the questions. And this is concerning, not only in relation to missed opportunities for disclosure and to provide support, but also in ensuring that sexual violence is captured in risk assessment processes. And as we know, sexual violence is identified as a risk factor for serious physical harm and homicide in domestic relationships. So in a health context, the physical signs of recent sexual violence for an older person may be similar to that of a younger victim and include bleeding in the genital area, bruising to genitals or breasts, pain in intimate area, or injury to other parts of the body. However, the physical signs of past incidents, of repeated incidences of sexual violence can be missed in older victims, particularly older women, as they can be seen as normal signs of deteriorating health in later life. But these can include repeated urinary tract infections, pelvic pain and uterine prolapse, incontinence, reporting pain during sexual activity, symptoms of sexually transmitted infections, which are often missed in older people, a history of multiple pregnancy and or miscarriage, which can be a normal part of a woman's medical history, but they can also indicate sexual violence in connection with a pattern of coercive and controlling behaviour. So contact with health providers across the life course can offer unique opportunities for disclosure for sexual violence, particularly for women. For younger women, this is a consideration in accessing sexual health, contraception, and maternity provision. However, a recent study by AVA has highlighted missed opportunities to ask about relationships, domestic abuse, and sexual violence with women seeking advice and support around the menopause. Key recommendations from the AVA study include that specialist support to manage the impact of both menopause and domestic abuse is in place, specialist support, menopause support workers or clinics, and tailored mental health support for coping with the impact of domestic abuse, specifically around complex PTSD and trauma. And that general practitioners should be trained to spot the signs and ask questions about abuse and or family and relationships during menopause-related appointments. Women should also be proactively informed about their right to request a female general practitioner. And general practitioners should increase their knowledge and access to relevant signposts in order to provide appropriate onward support for domestic abuse and sexual violence. So women reporting pain during and after intercourse is not an uncommon symptom of the menopause, and this does present an opportunity here to ask about relationships, particularly if they're experiencing coercion or force from an intimate partner. So there have been minimal studies also in the UK examining the mental health impact of sexual violence on older people. Small-scale studies which combine sexual violence perpetrated by strangers within domestic relationships and under the category of elder abuse have identified a range of non-physical impact and signs, which include fear, hypervigilance, difficulty in sleeping, fear of leaving the home or unable to stay living in their home, depression, anxiety, disassociation and PTSD, low self-esteem and confidence, distrust, reluctance to form new relationships and avoidance of intimacy, and feelings of shame and denial. And coping strategies include alcohol and substance misuse, self-harm, refusal or missed medical appointments, and distress during or refusal of intimate care. So it's quite easy to see from that list how these can be put down to just issues with mental health in later life, but could actually be the impact of sexual abuse. Shifts in relationships dynamics in later life can also be a point of actual or feared escalation of sexual violence, which can prompt a disclosure. So I'm going to share a short case study with you now from Dewa's Choice, which demonstrates this. So the case study has been anonymised, but we'll call her Carol, and she provided care for her adult son for 10 years. And she was undergoing a care assessment, and during the assessment she disclosed to the social worker that she'd experienced controlling behaviour and sexual abuse from her husband Peter in the early stages of their 60-year marriage. She was still married to Peter. So Peter's health had deteriorated, and Carol was afraid that she would have to provide intimate care for Peter, and that this would put her at risk of further abuse, including the risk of sexual abuse. The social worker halted the care assessment and gave Carol a space and support to talk about her experiences. A risk assessment was carried out and discussion of options for support. This included a discussion of the option to leave the relationship. And I must emphasise the importance of having these discussions around whether an older person does want to leave the relationship, because obviously there's, it's quite common for this not to be considered as an option when it's an older person. So Carol wanted support to continue living with her husband and to care for her son. This was the first time she'd disclosed the sexual abuse, and she wanted someone to talk to her about it. She felt that she could manage her risks if she had sufficient support with her husband's care needs, and she wanted to increase her social networks. A referral was made for ongoing specialist domestic abuse and sexual violence support. Care plans were devised to ensure that Carol did not have to provide intimate care for Peter, and that she had increased respite in caring for her son so that she could engage in social activities outside of the home. And this really is an example of a good practice response to a disclosure with pathways to support. So there are steps that practitioners can take to encourage and respond to disclosures of sexual violence by older people. And these include maximising the opportunities to create a safe and a private space for disclosure, asking older people about sexual violence, and it's important that we're comfortable with this and we're not apologising for asking. Employing professional curiosity. So if it would ring alarm bells with a younger person, it should also do so with an older person. And is age disguising the signs? And it's about providing a validating response. So you may be the first person they've disclosed to, or previous disclosures may have been met with a negative response. So be open and honest as well about when you have to share that information. So reassure that what has happened to the older person is not their fault, and encourage engagement with specialist sexual violence service providers. Acknowledge the lasting impact that sexual violence that happened in earlier life and offer pathways to support, and ensure that you're applying risk assessments and referral processes as you would with a younger victim. And sexual violence is a question on the domestic abuse risk assessment, as I mentioned earlier, and it has been identified as an indicator of high risk and a risk factor for homicide. So explore older options with the older person as well. They may not want to report the sexual violence, but they may wish to report it, and this should be treated in the same way as a disclosure from a younger person. So at Dewa's Choice, we have a range of resources for practitioners working with older victims of domestic abuse. And these can be found on the resources page of our website. And they include practitioner guidance, which is available in an ebook version to download, adapted power and control wheel on the lived experiences of older victim survivors, safety planning tools, domestic abuse and the coexistence of dementia practitioner tools, and a Forgotten Victims film that focuses on that area of the coexistence of dementia and domestic abuse. We're also holding an online event on the 30th of March, and this is to launch 2 short co-produced films and a tool for practitioners working with older LGBTQ+ victims of domestic abuse. And as we heard from Rory earlier, LGBTQ+ people are high prevalence for domestic abuse and sexual violence, but there are gaps in consistent data collection and gaps in service provision in this area. And this is a particular problem in terms of the intersections of sexual orientation, gender identity, and older age. There's also a link you can see on the slide here to a tool developed by Somerset and Avon Rape and Sexual Support Service, WSAS, and they've produced guidance for practitioners working with older women who've experienced sexual violence. So just for further information, we produce our research findings in the form of these tools and films and awareness raising, and also in our research publications, and these can be accessed through our website, and there's a link on the slide there. Okay. Right, thank you.
Thanks, Elise. Are there any questions or comments for Elise? I know there's been quite a lot of posting in the chat bar as we've been going, mainly links.
Yeah, I think my colleagues have been sharing links for me as we've gone along.
That's excellent. That's what we want. We'll make sure that we collate them all, so that we can share. Everything's available after the event as well.
Great, thank you.
So are there any questions? No, lovely. Okay, thank you, Elise. I found that really informative. So yeah, thank you for presenting today, and hopefully, you know, as I've said earlier, that we can get all services to work together and raise awareness, especially around some of the minority groups, and raising awareness about older people's sexual violence is you know, really important, and we need to make sure that everybody does recognize it. I was quite surprised that it was teenagers when you went into a secondary school weren't aware of older person's sexual abuse. So yes, thank you. Lovely, thank you. So that brings to an end today. So this was the 3rd event that we've held in the series. All of the links and video recordings will be shared on our webpage in due course following the events. We have one more event in the series, which is on the 30th of March, and that's the forensic in-person event in Cardiff. So it's just for me to say now, diolch I chi gyd am ddod a digwyddiad. Thank you all for attending the event, and have enjoy the rest of your day. Thank you.